Namaste. Today, we are going to visit this fascinating world of ultrasonography in pediatric regional anesthesia. 80,000 hours. On an average, in India, an anesthesiologist spends at least 80,000 hours administering anesthesia. If we need to be of maximum benefit, we need to be maximally beneficial to our patients. And in pediatric age group, I'm quite sure regional anesthesia is one of the best tools to manage perioperative pain. And when done well, we sometimes get a very small little thank you, which we kind of treasure. Coming to the subject, why do we require ultrasound guidance in regional anesthesia, especially in pediatric age group? We have certain reasons. Let's ponder on each of them. It's a dual modality. Pediatric general anesthesia and pediatric regional anesthesia are intertwined in the sense that the children are either sedated or asleep or given general anesthesia while a regional block is tested. So if we can become more and more objective, it is better we are. Superficial structures, because kids can be as small as 700 grams, yes, and as big as 95. But then most of the structures here are superficial, especially in infants and neonates. There are a lot of congenital anomalies which can make landmarks a little difficult to understand. And if ultrasound scan opens up what we need to see, it definitely adds on. And because of their small weight, the dosages are always limited, and hence I think the dosage sparing property of ultrasound guided regional anesthesia can be actually exploited to the maximum in this age group. So this is a plethora of sizes and various shapes of children that today we encounter. They could be, as I said, as small as 700 grams and as big as 95 to 100 kilograms of an adolescent coming to you. Plus there could be kyphosis, scoliosis, there could be anomalies in the hand, anomalies in the feet, and not to say other anomalies such as cardiac, such as other systemic, any systemic anomaly for that matter. But let's come to the central neuroaxis block, because this has been here for years together, and then we shall soon later on move to peripheral blocks as well. So coming to the central neuroaxis, I think the best possible aspect that central neuroaxis has indeed imparted to pediatric anesthesia as such is the simplicity that it has. If a little baby has to be anesthetized with with very simple technique, say for a cystoscopy or a hernia or any for that matter, non-cavity invading surgery, any superficial surgery, we can do it with simple mask and a well-placed caudal block. And the baby kind of keeps on breathing on her own, and the surgery happens without much change in the physiological milieu. Let's understand the scans here with the caudal block, so that we're very clear about the markers that it actually offers to us. Let's understand the longitudinal scan. For that, the probe placement and the needle placement is here in front of you, and the probe is longitudinally placed with the orientation marker towards the caudal side or wherever the anesthesiologist prefers. So with this particular scan the transducer placement, the scans are going to be as follows. This would be the posterior of the patient, the anterior of the child. This is the caudal, and this is the cephalad. This will be the skin and subcutaneous tissue. These are bones. These are sacral spines, and hence you can see that there are shadows here, and you can see the entire filum terminale, and this is the base of the sacrum. So this actually is the caudal epidural space, which is filled with the filum terminale. The needle has already walked amidst it, and we are yet ready to inject the drug. If the probe is moved, cephalad, we can see the conus and the posterior dura and the CSF here, and the entire spinal anatomy, the entire neuroaxis is actually open to us. These are again the spinous processes, and you can see the shadows imparted by them. This is the posterior dura, the ligamentum flavum, and then the CSF, and this is the anterior part which actually is the posterior aspect of the vertebral body and the posterior longitudinal ligament. So I feel if there is any place to understand the spine best with ultrasound, it is the pediatric operation theater. So having understood this particular aspect, we can now open up so many complications in our minds and understand how they can be actually diverted out or cancelled out because of what we see. The most dreaded complication of all is putting the entire local anesthetic, which is calculated for an caudal epidural, into the CSF itself. So if you see the conus and if you see the CSF, it is extremely unlikely that the needle would come. We have a good chance of withdrawing the needle and not putting it where it should not be going at all. So we cannot be subcutaneous, because if we were to be subcutaneous, we would see the needle right here. We could not be even beyond the base of the sacrum. Another complication staring at us would be injury to the sacrum and sacral osteomyelitis. That gets prevented here, and now the needle is in the correct place, not too close to the conus as well, and we can very safely inject the drug. So here is the conus, which we are just about to puncture, but we cannot, or we should not, because we can see it. Well, having injected, what else does ultrasound really open up? It can act as a surrogate marker, even for higher spaces. In the sense, if we have injected the drug right from here, we can keep the probe at the vertebral level that we want to have a look at and see if the dura has gotten displaced because of the injectate. Let's look at this particular video to understand what we just said. So this is the phylum terminale. I'm going to see the needle walking in inside, and this is our baby. This is the conus. We should not be puncturing the conus. I've injected, but I can see that there is a tinge of was air, which along with the local anesthetic, the air might have been in the hub of the needle actually, and I'm still in the epidural space, which is a bit anterior. We would like to be in the posterior epidural space if possible, and that is how the injection would be conducted. So you can see that now the actual drug walked on like this ahead. It would be more clear in a while now. The needle here. This is slightly older child, and you can see the needle sitting here and the injection going on. This is the conus. We've gone above, and you can see that the posterior dura and the anterior dura kind of come towards each other, because this is the drug which has taken the place and it's pushing the posterior dura anteriorly and the anterior dura posteriorly. So this is how it can work as a surrogate marker, and this is how we can be very sure that the drug volume indeed has reached the level that it has to for the given surgery. This is the static scan that I wanted to elaborate upon. So this is the posterior dura, this is the ligamentum flavum, and this is the drug which has occupied the space here, the potential space in fact, and this hasn't happened yet here. Again, just to have a very broad view of this, this is the drug which is here, and this here, the displacement hasn't happened. So how have we made it really simple is, by this modality, we can avoid opioids, we can avoid even deeper general anesthesia as such. So if we are anesthetizing a small little child of say 1.2 grams for an exploratory laparotomy, and then we have induced and we've given a very good caudal at the time of extubation, we can have a very clear, peaceful picture. You can see that it was, let me go back to this particular video. I want you all to understand that she can move her upper extremities, but her lower extremities are not moving because of the caudal block that we just gave. And then once she's extubated, The facial expressions really say that she's quite pain-free, comfortable, she's breathing well, and note she's without oxygen just after an expiratory laparotomy. So this is what regional is actually giving us today. And if employed properly, I think we can give analgesia to neonates without respiratory depression. We can give analgesia to toddlers and infants without much nausea, vomiting, without much side effects of other analgesics such as NSAIDs and opioids. It can be a very good teaching tool in the sense we just said that we could be in the skin and subcutaneous tissue itself and not actually where we could be. So it is a very good teaching tool for the residents. Or if we have had a habit of simply putting in a probe before we give a caudal block, and if something such as a discoloration or a sacral dimple tells us that this could be an anomaly here, we can actually scan, see a cyst, and if it looks innocuous, we can still go ahead and give the benefit of a good caudal block to the patients. Now, local anesthetic and dosages is something that we need to be very, very sure of, and the calculations need to be perfect in this particular age group. So it goes like this. If it is ropivacaine, it is 0.2%, 2 milligram per kilogram, or bupivacaine 0.25%, 2 milligram per kilogram, lignocaine adrenaline 5 milligram per kilogram. The volume depends on the site of the surgery. Say for hernia, we do not hesitate using 1 ml per kilogram of volume, keeping milligram per kilogram constant. Circumcision 0.5 ml per kilogram fine. Bilateral tenotomies again 0.5 ml per kilogram serves well. Cystoscopy fulguration 0.5 ml per kilogram fine. So the division of below the umbilicus and above the umbilicus, I'm not too sure how well it will hold true, because the incision of a hernia is actually below the umbilicus, but the innervation comes from T10. So we do need a higher volume for hernia or opexies. Continuous lumbar epidurals, yes, if we could take the trouble of putting a single shot epidural, we could go ahead and put a lumbar continuous epidural when indicated in invasive procedures. Let's look at how it is done traditionally. We use a 19 gauge epidural needle here, and the loss of resistance here is elicited by saline. So this is a 19 gauge epidural needle used, specifically made for neonates and small infants. And now if you can see, the dominant hand holds the needle very close to the tip, and the non-dominant hand continuously gives the pressure on the plunger. And we elicit LOR with saline. Not much of saline is injected because we do not want to mix it up or confuse with spinal tap. The epidural catheter walks in. This has been charged before with normal saline so that the air is flushed out. It might become a bit difficult at times to thread in. A slight opening up of the angle works. And mind you, even if at this particular point if it proves difficult, the catheter can be withdrawn and we can actually dilate the space with some more of normal saline. I can see that there is some blood here in the hub. I'm going to see whether it is external or internal, because by that, what I mean is you can wipe the catheter and see whether it is right inside the catheter or outside. If it is outside the catheter and it gets cleaned because of the wiping, gentle wiping, then we are safe to give the local anesthetic. How do we add objectivity? For this, we need two operators or two anesthesiologists, one who's efficient in carrying out the lumbar puncture and the other who can actually follow the lumbar puncture. In the sense, maybe one or two levels above the level at which the epidural is given. We need two experts for this particular work. And the sterility has to be precise. In the sense, we can ensheath the entire ultrasound probe with the camera cover, and then we can either put a tegaderm on it or we can put a glove on it and make it totally sterile. Because central neuroaxis block, the two continuous ones, need a lot of respect, and it has to be done in one of the most diligent manner, especially the asepsis. So if an LOR is elicited, what we see is a proper dural sac in the levels above it and perhaps even below it. So this is the displacement due to the drug injected or the local anesthetic injected. May I add to this that you can actually see the catheter walking up in a transverse section if it is followed well at this particular stage, which I haven't done here as yet, but still a suggestion. If we really come across difficult cases such as operated meningomyelocele, well, a caution here is it still remains a very delicate job to do. But suppose if the risk-benefit ratios do drop towards having a central neuroaxis in these particular patients, such as bilateral foot or hip or intra-abdominal major surgeries where analgesia is pretty important, then what we can do is we can now choose a well-formed vertebrae with a normal osseous architecture and work in that most normal looking intervertebral space, sparing the vertebral spaces where the scarring and damage has occurred. So this is an abnormal area, and you move it up and down and pick up a normal area, which is as follows. So we could leave the abdominal area totally aside, and we can pick up a normal looking interspinous space or intervertebral space to work in and put the epidural catheter. But may I say that it still remains a precarious job. The easiest technique today to do and render continuous analgesia in the age group which is most vulnerable, that is neonates, is passing catheters through the caudal space. Dr. Adrian Bosenberg has taught us this long ago. What we can do today is add a lot of objectivity to it by adding ultrasonography. Traditionally, how we did was we palpated the caudal space, and then we understood that maybe the incision was here. So we actually measured the distance, and if the distance measured said that okay, this was 14 centimeters from the caudal, we actually pushing the catheter from the caudal 14 centimeters from the skin, assumed that the catheter indeed has reached here where the tip is supposed to be, so that we give an absolute site-specific analgesia. But did the catheters really go where we thought that they should go? Let's see. So what we did was we actually followed the catheters all throughout in their course, and this is, well, even before I go ahead, there is one thing I need to say. We should not and we cannot put catheters in everybody unless we have a good team to look into. One catheter going wrong can undo all the good work that we have done till now, and we can go back again to square one where we were hesitant to put catheters. So a good team, a good PICU, a good NICU, go ahead, put catheters. Your surgeons should understand what you're doing as well. If there is no proper teamwork, I don't think we must venture into catheters, especially in this age group. Well, coming back to our catheters threading to the caudal space, the journey will look something like this. So this is the catheter moving up. And now, the moment we keep on passing more and more of catheter, we keep on threading more and more catheter, we actually can follow it up like this. The catheter sometimes would be seen in the posterior epidural space. So this is a real-time catheter movement happening here. You can see it all the time here walking up. I'm showing you different age groups here, in fact. So 3 to 4 months, the conduit is open for us to see all that we want to see. Sometimes, to our surprise, you can actually see it in the anterior epidural space as well. I'm trying to reverse the video a bit for you to ponder on this particular aspect. So the catheters do walk in the anterior aspect as well. And then sometimes we do not see the catheter, but if we inject something, we actually see the catheter moving right, displacing the dura. What I meant here was, this is again the dural displacement that you have seen because of the LA that was injected through the catheter, or saline for that matter, if you don't want, if you're not too sure about where the tip is. Another way is you can actually push in the catheter from the other end and then from the lumbar end and then see if it is jetting out here. Suppose if you have any issues here, say sacrococcygeal teratoma or something like that, so go from the lumbar and give analgesia again and become and let your catheter be site specific. And then tunnel your catheters, because this is not a very clean area. So what we can do is we can tunnel it and give a covering of skin so it remains sterile. It's not a must, but if a habit is developed, it's good. Secondly, once the infusions are set, the syringes or whatever pumps you use, they need to be labeled well. They need to be separated. There has to be a warning that this should not even by mistake put in IVs, because that can really be very, very catastrophic. And we need to follow up every catheter. That point is worth stressing 100 times. Secondly, we are going to often get calls from the PICU or an ICU that the catheters are leaking. Usually there is a back leak because the pressure gets built up in the epidural space, and so it just gets back leaked. The back leaks are accepted. Whatever needs to be gone inside does go inside. So continue with your infusions, let the back leak happen, put a pressure dressing, but tell everybody what is expected so that they do not get really worried about it. And pull out your catheters thinking that, well, the catheters are not working well. LA dosages with an everyday example, especially for infusions, we need to be very, very clear about the dosages. The only drug that suits the infusion well is ropivacaine. So in infants and neonates, at least we must go to ropivacaine when we are putting infusions. So ropivacaine is in the dose of 0.2 milligram per kilogram per hour. Say 1 ml of 0.1% ropivacaine shall so now have 1 milligram of ropivacaine. Suppose if I have a 2 kilogram neonate, then it is 0.2 into 2, which is 0.4. So infusion of 0.4 ml per kg per hour of 0.1% ropivacaine. Label it. Have a caution of not attaching it to the IV, and your infusion is ready to be started. So, but what we observed was something very interesting. Does ultrasound add accuracy to continuous caudal epidural catheters, especially in this age group? And we found that yes, it does. What we found, well, that it does is perhaps not a very big news, but what we felt was the secondary objectives said more. It did not depend upon whether we wanted to reach lumbar or we wanted to reach the thoracic level. So it did not depend on how short the distance the epidural catheters had to travel. The chances of it not being site specific remained the same. It did not depend whether it was a neonate or whether it was a 3 months baby. So it did not depend on the kilogram. It did not depend on the level to be reached. So we getting missed with the catheters can happen at any level and at any age. Coming to transverse scans, in fact, they help us very much in single shots. Transverse scans are also very easy to understand, and transverse scans, in fact, can be worked into even in adult population. Well, transverse scans go like this. So in this particular scan, if this is the transverse section, this is the posterior and this is the anterior of the body, if you can compare the two eyes of the frog here, then they are the sacral corners. Okay. Now, if you can compare this particular part, then something joining the two eyes, which is actually the sacral cornu, then this is the sacrococcygeal ligament. Below the sacrococcygeal ligament, the mouth of the frog here is the base of the sacrum, and amidst the two is the potential epidural space. So this was the base of the sacrum. When we observe a dynamic scan here, what we are going to see is we are going to see the tip of the needle coming all the way here, and when we inject this potential space, which is beyond the sacrococcygeal ligament and before the base of the sacrum, is going to get expanded. So this is the space, the potential space that we are going to be expanding, and this is essentially going to be an out-of-plane work. But sometimes, alas, the best bet is last. We may not have central neuro axis to work upon. And secondly, modern pediatric regional anesthesia does believe that we must be going as peripheral as we can with our techniques and not remain central, because it has been proved by so many studies that the complications that happen during a central neuroaxis blocks are more severe and more than the peripheral blocks. In fact, peripheral blocks have as little complications as zero in literature. Having said this, I think they have a role to play and we need to master them, because, say, for example, caudal epidural is one block that can fit many pills. Say, for example, one more case, say, absent sacrum, difficult to go centrally. Well, now, so we can go beyond caudal, especially for lower extremities. What we can do is we can go both ways. We can go sciatic and femoral here, and we can work upon, mind you, lower extremity. Please think of both the blocks unless we are working on the ankle without a tourniquet. So baby is sedated. We take a transverse section as I'm showing it here, and the needle can be given, put in plane, under vision, or we can go out of plane as well. Here I have shown a baby in lateral, but you may as well keep the baby supine. You may as well give a lithotomy position. For kids, it's very simple. Somebody can just simply lift up the child's leg for you to work upon. So what we see is a beautiful anatomy of this kind. This is the posterior, this is the anterior of the body, and then what we can see is skin subcutaneous tissue, biceps femoris, and this is a good sciatic nerve. We could have actually done with a lesser depth to see this even better. Now we can see the needle right sitting next to it and the hydrodissection that is happening due to the drug itself. If I may, I might walk to posterior. If I may, I could dissect more on the posterior as well as the anterior aspect. All right. And if you see, I have injected more than enough of local anesthetic. But at this point, would you not agree with me if I say that this becomes a perfect background for me to put in a catheter and actually visualize the catheter very well under the background and echogenicity of the entire drug. So we are going to see this in the next video here. Simple Tuhi needle can be worked upon here. So the Tuhi needle walks in right here. You can even see the lumen. I can see the sciatic nerve right anterior, and we can see the catheter jetting out of it. And we can fix the catheter at this particular distance, and you can give a continuous catheter, sciatic perineural catheter block for a child, say for example, for ankle fracture or for CTEV repair, that is congenital talippoequinovirus repair. But don't forget to tunnel the catheter, and also remember the catheters are going to leak. Now here what I'm showing you in this particular video is a longitudinal section of the sciatic nerve. So if you have put in a catheter, it is worthwhile to follow the catheter all along the longitudinal axis of the sciatic nerve. What interestingly we found while in our course of work is, even if the needle sat next to the sciatic nerve and we stimulated it, not always we got a response. But when we injected, notwithstanding the presence or absence of stimulus, we kept on getting a block. And then it's of course feasible to keep catheters by very, very simple techniques if we have ultrasound guidance in these small kids. Now, small kids, but perioperative pain is not that easy. Perhaps it's a bit tricky. Look at this particular fellow. He's 2 years old. He's in the post-operative period, maybe 2 hours, lobster foot, which is just corrected. He has bilateral one is acted upon, worked upon, operated, another one is not, and to that foot a sciatic block is given. But look at his face in the post-operative period. Seems to be in pain, quite agony. Look at his, the brows are together, eyes are together, and looks as if he's in pain. Now let's see what happens here. Since it's 2 hours, I thought maybe he's hungry. So that did the trick. But the regional anesthesiologist in me is not quite too sure yet, because he should not have cried any which ways, and I am curious to know whether the block acted. So what I do is I put a gentle pinch on the leg which is operated and blocked, and the suckling goes on. And I gently pinch the other leg. Well, so the story is telling itself to you. Now, you can get congenital anomalies where the knees could be contracted, and we may not get a nerve stimulation response here at all. At this time, ultrasound does add a different dimension, and we can now put blocks where we otherwise would have hesitated putting for the sake of efficacy. And this is an in-plane technique, an out-plane technique also can be done, and this is a short video to show how it works here. So this is the anterior, this is the posterior, this is the femoral nerve, this is the needle which is just anterior to it, encircling the entire nerve as such. But it's not necessary to go anterior as well as posterior. Even if you sit in one corner and do that off, it's fine. I mean the needle. Now, what I'm trying to show you is we have just inserted a catheter with a 2He needle. So instead of a nerve stimulating needle or any needle, short bevel needle, if we can put in a 2He needle and give a continuous femoral block here, well, it works. And now put in a catheter and don't thread it much. Remove it, remove the 2He needle, tunnel it, and then you can even, this is the catheter, you can see the catheter here, and if you can inject the drug through that, you will see some hydrodissection happening due to the drug which has come through the catheter. So placements of catheters can become very, very cost effective once we have this, because we do not now have to spend on the stimulating catheters or a specific catheter set that otherwise is a pretty little expensive than the epidural catheters. Congenital anomalies such as arthrogryposis or such as radial club hands, let's dwell on arthrogryposis for a change here. The joints are fixed, they're not going to move. The muscles cannot be identified well because they all are into they are fibrous enough, so the transverse section is going to look like nerves. So sometimes you need ultrasound for sure in congenital anomalies at least. Coming to fascia iliaca compartment block, this is also adding a lot of different dimensions to regional anesthesia, especially for surgery such as a plate removal, a distal or a mid-femoral plate removal. So this becomes easy, not invasive enough to go to the central neuroaxis. Again, lumbar plexus can become far more invasive for something like a plate removal, but do not underestimate plate removals. They can take their own time at times, even longer at times than actually the real surgery. Well, so this is how the probe is kept. This is how the needle is injected, and then the fascia iliaca here is traversed through with the needle, and the drug is deposited. This is the ileum, this is the iliacus, and this is the fascia iliaca. Coming to upper extremity blocks. Well, if we do not know lower extremities, we have our central neuroaxis to work upon. So it's very rare that you're really going to miss a lower extremity block in children. But upper extremity blocks, I think we need to master them. And if we have ultrasound and we do upper extremity blocks, the success rate and I think the complications are really, you can increase the success rate and decrease the complications for sure. And in congenital anomalies, it is going to be tremendously helpful. This is what our work has told us till now, and let's see how. Well, so we can categorize the blocks as above the clavicle and below the clavicle. So, having said this, interscaling in children is rare. Not very many indications. Maybe a very proximal humerus cyst, or still that can be done in subclavian perivascular, or maybe a shoulder, springle shoulder. And again, springle shoulder, they are going to work on the back as well. So it's going to be an incomplete block. But any which ways, you might get shoulder abscesses in newborns, in septic kids. So there could be very, very discrete indications for interscaling. So one such case was a neonate with sepsis in the shoulder joint itself. So all we had to do was tie a mask and go ahead with the block. Yes, a bigger footprint probe also does work. In fact, it shows you shows a bigger anatomy as long as we know how to work with it. So you can see the pus coming out here, and all we had to do was put in a SIVO mask and put in the local anesthetic right next to the interscalene. Here there is no distinction between the subclavian artery and the interscalene groove as such. So all that we did was we injected the drug just above the subclavian artery. Coming to supraclavicular or subclavian perivascular approach, again, this is one important block. Yes, you can have most of the nerves of the brachial plexus worked on in this, and it has come in vogue, especially after the advent or application of ultrasound in this age group. So this probe is cleaned and then sterilium, with sterilium till here. Please do not put any alcohol solutions on the footprint. Cover it with a good sterile tegaderm, and then this is how the block is done with an in-plane technique, and this is the interscalene of a little baby, and you can compare with the interscalene of an adult. Look at the depth at which we work here at 2.2, the depth here is say 3.3, and the traffic signals here really look big, unlike those which you can see here in a small child. Well, having said this, we also have to realize that anatomy in kids can get challenging because they're soft, they can be boggy, as much as it can get very challenging in an obese individual, in an adult. But none the same, both deserve good perioperative analgesia. So sometimes we have even gone ahead and put catheters where it was absolutely indicated. Coming to infraclavicular, nothing is more helpful than infraclavicular in adolescents, because most of the times the injuries are on the elbows, or small children, very small, say 8 months, 9 months. This is the typical age where they come for radial club hand repair, and radial club hand repair again is a tricky congenital anomaly where the radius is absent, the muscles arising from them are absent, so the end motor response that we could have otherwise elicited with the PNS is going to be a little blur and confusing. So we are going to depend hence on ultrasound to get the good block out of it. So the architecture here is again very simple. All that we need to do is keep a probe the way it was shown here, shown in the previous slide. So this is the anterior, this is the posterior, the orientation marker is scaphoid, and all that we need to understand is this is the pectoralis major, pectoralis minor, and the needle comes in here at say 6 o'clock, which is the posterior cord, supposedly posterior cord position, and then maybe say 9 o'clock, supposedly lateral cord position. What happens in kids is the pleura is far much closer, so one needs to be very careful. So this is how it would, the probes can be placed in very small children. This is, I'm comparing it to the adult here. You see that the pleura is very close to the brachial plexus, and pleura is hardly seen at all in the same scan, in the same picture or the same sagittal, parasagittal section that we are looking at in an adult. So one needs to be pretty careful with kids. As we just said, that too much superficial structure is also not a very good advantage. So in one go, we can place, at times we can go even ahead, but what remains again crucial here is really to separate or go beyond the fascia that covers the pectoral. Otherwise, we could inject intramuscularly and we wouldn't get a block. And look at the pleura all the time. We can put in a catheter again. The moment we create a anechogenic background, put in a Tuohy needle, put in a catheter, just 2 to 3 centimeters beyond the Tuohy needle, tunnel it, fix it, and put it to an infusion pump. we get good continuous catheters or continuous intraclavicular techniques by this attitude, because infraclavicular area really renders itself extremely well for anatomical fixations, because we are not going to, I mean, the kid is going to be wiggly, but since there is no much movement happening here, unlike the axillary or the neck, this really works well. We wondered whether it really worked well, and hence we first few blocks we really put in a catheter that way and injected a bit of dye to understand that we were most of the times, not most of the times, 100% of the times we were in the brachial plexus, when under ultrasound we went just posterior to the cord, or rather to the artery. And this is our work which actually tells us that ultrasound by itself is enough. In NICUs, when the arteries are damaged, we can extend our services to improve the circulation, because the somatic and the sympathetic supply to the upper extremity is intertwined. So if we can give a block, it will increase the vascularity and it will reduce the watershed area, and the damage that could have been really far much more, we could limit it only to the tip of the fingers in this little baby whose artery was punctured and damaged. Coming to axillary, this is one simple block most of us actually can master. So again, we are ready here with the catheter if we wish to. I haven't put it, but this is just this is just a mock picture here, and this is how the probe would be placed. So it would be, again, we do not aim at one particular nerve here. Just above or below the artery serves the purpose. If the child is a little grown up, we can go all along the artery, because the nerves are going to be in a mnemonic of R, U, and M, posterior to the axillary artery. Sorry, I showed you axillary vein. I'm extremely sorry for that. Let's come here. This is the axillary artery. 12 o'clock to the artery. Supposedly, I said supposedly, yes. The median nerve. Posterior to the artery would be the radial nerve, and say maybe in between the artery and the vein would be the ulnar nerve. So R, U, and M. That it can go by that mnemonic. Hence, the anatomy needs to be very clear. If you're very high up in the axilla, you're going to get the latissimus dorsi. If you are slightly in the middle or lower axilla, it's going to be the triceps, and then there is going to be biceps and coracobrachialis, the skin and subcutaneous tissue, and the axillary artery and the axillary vein. Although this is an entry-level block, it needs a lot of skill, because there are two big vessels looking at you all the time, and the nerves are not so discrete. The nerves are there, but they can be very differently placed in this particular block as such. So if we can master axillary block to begin with, I think we are ready to give all other blocks as well. So this actually is a very, very good entry-level block. Coming to trunks, I haven't covered the entire plethora of what's existing in the literature today, but I have covered some few which have established themselves. So first is the rectus sheath. Where do really trunk blocks help us? They help us in minimally invasive surgeries such as laparoscopic surgeries. Say, for example, a 15 kilogram baby comes for a lap appendicectomy or a lapopexy. The internal work is not going to be very painful. The ports are going to be painful, so we can anesthetize the abdominal wall as such. Same with the appendicectomy of a 25 kilogram. But maybe a laparotomy, I think I would still go to a pristine, clearly placed epidural, unless there are any contraindications. If there are any contraindications to central neuroaxis, I would definitely come and offer analgesia through trunk blocks. Remember, as we said, abdominal wall blocks, whichever we are discussing right now, are going to give only somatic analgesia, and there is not going to be any visceral analgesia given by these blocks. So it essentially becomes a multimodal approach. We do continue with our NSAIDs, or we do continue with our tramadols, or whichever other post-operative pain management regime we are looking at. And this definitely takes a big chunk of pain away, which is of port insertion pains. So this is they can be given before the operation, or they can be given in the post-operative period where the dressing has already been done. So it depends on how you, the placement depends. Although we as anesthesiologists would always prefer the blocks to go before the surgeon puts in the trocar. So this is the probe position, and this is how the needle and the syringe will enter inside. So we can see the rectus sheath here. This is the anterior, this is the posterior. This is the skin and the subcutaneous tissue. We can see the rectus belly. This is the peritoneum. So if you want to note here, the distance between the posterior rectus belly and the peritoneum is hardly what? In mm, because this itself is 1.8 centimeters. So if this entire thing is 1 centimeter, so this is in millimeters, I guess. So the needle has to come in plane, under vision, or out of plane, or the same under vision, and not beyond this point at all. And then we place our needle just proximal or before the posterior rectus sheath, and then inject the drug. So this is how the real good injection would look. You will have two the peritoneum as well as the posterior rectus sheath sinking down because of the drug, and this is the muscle that has gotten separated, and it creates kind of a spindle shape or a hammock shaped spread. This is again the ilioinguinal iliohypogastric block for the most common surgeries that can be undertaken in infants, which is a hernia surgery. But if this is an analgesic block, I do not claim that the entire surgery can be done only in this block. If we need to follow a technique where we are going to give minimal general anesthesia, we are going to ask ourselves to totally spare or reduce the general anesthetic as much as we can, then we need to choose that particular block which is going to render the entire operability, and the analgesia and the general anesthetic would be as much required as to keep the baby immobile. So it is going to be minimum, and the operability rendered by the block, I repeat. So a caudal, well-placed caudal with a good volume required for, say, hernia or an opexy should be given if that is our approach. But if our approach is just to give an analgesic, we are going to give general anesthetic, or we are going to intubate, give a muscle relaxant in any case, go ahead, give these blocks. They're going to give you a very good intra and post-operative analgesia, along with, of course, a diclofenac suppository or whatever other suppositories or multimodal drugs that or analgesic agents that you're going to look at. So here is the needle coming back to the nerves here. So this is the anterior, this is the posterior, the external, internal, and transverses, and these are the two nerves underneath with which we are going to deposit the drug, or just next to it if you deposit, that's going to work well. So, and this is the anterior superior iliac spine. So this is the needle just about to deposit the drug. This is a tap block. Well, we could have given a bilateral tap in this particular case, because finally we may not really require a rectus sheath block again if we are giving two bilateral taps here. All right, but then we could do bilateral for sure. Whether you give rectus sheath or tap, make sure that they are on both the sides, unless the surgery is only on one side. But if it's an umbilical port, bilateral work needs to be done. Again, here the tap plane is extremely easy to understand. This is the anterior of the patient, the posterior of the patient. This is the external oblique, internal oblique, transverse abdominis, and this is the peritoneal cavity. So our job is to put the local anesthetic in between the plane of internal and the transversus abdominis. So this is how it would work on. The needle has been bought in between the internal and the transversus. The peritoneum is here, and we are going to peel the transverse, this particular plane. Let's see how. And by this, we are bathing the nerves which are actually lying in this plane towards their path. So I know I haven't completed the entire plethora of what regional anesthesiologist with ultrasound can do in peds. We have left paravertebrals, we have left the QLs, and we have left the erector spinae. And not all blocks are covered, but the most useful blocks I feel have been covered. This is a fascinating world because, as I said, neonates get pain, they deserve pain relief. So do infants and toddlers. And we do not want to give analgesia, which can cause respiratory depression, nausea, vomiting. And here is the best bet. And if we want to avoid complications, I think at least to some extent, a lot of objectivity can be added by ultrasound. Does this world fascinate you? Thank you so much. It does to me. Thank you for listening. Before I really say goodbye to you, I want to share that the Children's Anesthesia Services, which is a group dedicated to children's anesthesia, and many hospitals in Mumbai outsource their work to us. We run fellowships in pediatric regional anesthesia in collaboration with the WFSA and Academy of Regional Anesthesia, India. So if there is anybody who is interested, you're most welcome to join us. Thank you.